All right, good afternoon, everyone. Thank you for joining us. Today, we're joined by Opal Greenway from Stroudwater. Opal will be presenting over leveraging RHC data to drive outcomes. We are a small group, so if you have any questions, comments, if you want to share best practices, we love to have interaction with everyone on the call. You can unmute yourselves, you can type in the chat, and I'll be sure to man the chat. And so with that said, Opal, I'll turn it over to you.
Well, fantastic. Thank you everyone for joining us, whether live or on the recording. So within this series that we have been talking about with regards to RHCs of really, how can we do better, right? And so one of the key things that we want to talk about in this series is the data and how are you going to use that data to drive the outcomes? So things I want to go over with you guys today are what we see and what we actually see with our better performing performers. Right. So what is going in an RHC that actually is driving this kind of performance? What kind of things can you expect? What is the data that we actually are using to drive that decision making? How can we ground ourselves in that data? And what are the best and the key piece of this? What are the best practices that we're actually seeing people operationalize using this data driven thing to get to that better performance? I will say as we go through this, I have in here some tools and checklists. So my understanding is that this is going to be sent out to everybody. And so you will be able to have that. You'll have your own little checklist associated with it that you can go through with the with the PDF of this PowerPoint to hopefully actually help you start launching, utilizing data for driving that performance. So let's start off with some ground setting of what's going on as to why we actually need to be paying attention to the operational performance of our clinics. What causes them to not be doing well? Because understanding that, to me, of understanding why something might not be performing how I want it to, helps me understand what's the data I need to monitor so I can make some really good decisions about fixing it. One of the things that we've seen really is that hospitals and health systems that own clinics, they'll buy up a practice from a physician. What typically happens is a provider who is in the community, who has a strong relationship with the hospital, maybe has referred a lot of patients to them over the years for their ancillaries, for specialists, et cetera, says, I don't want to run my practice anymore. I just want to see patients. Will you buy up my practice, right? I just want to focus on healthcare, like actually seeing patients. I didn't go to business school. That's not why I became a doctor. And so a lot of hospitals and health systems will be really opportunistic. A practice comes up for, that wants to be sold. The hospital wants to keep the referrals in that patient list. And so they buy up a practice and employ the provider. Rather than really actually being strategic, there's nothing that are grounding in what is our medical staff development plan? What are the resources that are going to be needed to integrate this practice? If I bringing this practice online, say, this rural health clinic, that means I can't execute. It's the same people. We work in rural healthcare. Most people are wearing 10 different hats, which means I can't go out and actually have somebody develop a new orthopedic practice at the same time, right? Because it would be the same person doing both things, or that same person will have to do both things as well as their full-time job and maybe not do it as well as they could. So the consequences is that, when you don't do it based from a strategy that you're trying to execute and you're being opportunistic, it has some downstream consequences, right? Is you don't fully take into account the infrastructure changes that happen. You're not really smart about the consolidation that is appropriate. So they either do no consolidation and let the practice go, we'll buy up the practice and do no integration whatsoever. And the practice continues to operate the way it always is, but now it has more overhead because we've changed provider compensation. We've added in benefits for all the staff now at the hospital level, and we've changed the HR system that has investments, right? Like that's a serious IT benefit or IT investment that we have to make. And so we are not smart about what should be consolidated versus what is not. And we've done this with practice over practice or practice. So there's no standardization across it. Every provider's on a different contract. We have a different standard workflow within each practice. Nobody's checking in patients the same way. Our revenue cycle is not integrated, and all we did was we made sure everybody was on the hospital contracts, right? And now we're using our hospital billing group, who, by the way, has never done RHC billing before, right? Or we're using a third-party vendor to do our revenue cycle, and they don't specialize in RHCs. So when you add all these things together, what we see really is hospitals and health systems hosting practices rather than actively managing them. And so, lack of actively managing them, they're not paying attention to what is the appropriate data to make the right decisions, to really drive that operational performance and get them to being a better performing practice. So, what do we actually see in a practice that's doing well? Well, every practice that we see that's doing well has some key attributes, right? And they start off right off the bat with organization and strategy. Okay. You actually have a strategic plan that you're trying to move forward as an organization so that you can understand, where does the RHC actually fit into driving this strategic plan? Where do we fit into, so that we can understand the decision making and the resources that are necessary for moving the organization as a whole forward? Are we just some small piece of the puzzle? One of the things that really stands in the way of practices doing well and organizations doing well is an us versus them mentality. And this happens in clinics all the time, where it's the hospital versus the clinics. And they're not really at odds with one another. The clinic just feels kind of like, the stepchild, right? We're not getting the attention we need. The hospital makes their decisions. They're doing their own thing. And we're just here, doing our best to see patients day in and day out. But we don't know why the hospital is making this decision. Instead of looking at it from a health system, the hospital is making decisions, right? As opposed to what is best for the health system. And having that strategy and being able to point to every decision we're making, this is how it fits into the strategic plan. This is what is driving forward. And engaging with the RHC about that is one of the key things that we see starts off to be able to move towards being a better performing practice, right? So that we can say every decision fits into strategy. That's data. That's not just, people think about data just being numbers. Being able to tie information together of, okay, here's the decision and here's where it fits into this strategic plan. That's information and data that is, hey, we've made a decision that is based on the data that says these two things tied to one another, right? And then we're going to think about how are we going to measure the success of that. So having that grounded, we see in all of our practices that are doing really, really well, have that at the heart of them. That being said, all of the operations are very much run through data-driven decision-making, right? And they're looking at it at the clinic level, not just at the whole organization. You understand what's going on with revenue cycle management at the clinic level. You understand staffing at the clinic level. One of the things that anytime I'm going into an organization that wants to do operational performance improvement, I'm asking, do you have the data at the clinic level? And if they don't, I can already tell you that is one of the key areas for improvement, is we're not getting to a granular enough level in order to actually make appropriate decisions for that RHC when everything is rolled up into an okay, here's everything is in all outpatient, right? And now you're mixed in with PT and you're mixed in with every other clinic, right? That makes it really difficult for you to use that data to drive decision making. We pay attention to productivity, right? That is the data that most people are familiar with. We understand visits and we understand work RVUs, but we're not always looking at all the different things that are impacting productivity, such as, hey, is provider compensation, are providers and staff actually incentivized around productivity? And a lot of times we see that they're not, or that maybe you have in your provider contract, say they get an incentive payment for hitting some level of productivity, but the metric is not, nobody's hit it in years. And so why are we still using that metric or that level of that metric to actually drive performance, right? An incentive that nobody can ever achieve is not really an incentive. You basically have people on base salary. Well, if you're not looking at the data on a regular basis of how many times are people actually getting that incentive payment and how much of their compensation is in that incentive payment, then you're not using data to drive the performance of your practice, and you're not going to end up in that better performance. Organizations that we see that are really high performing at every decision, they can tie also to how are they driving value. We are moving along that spectrum of moving towards more value-based reimbursement, we're trying to move to healthcare instead of sick care. And so understanding and putting the community and patients and understanding them as the critical stakeholders around every decision we're making and saying, how does this operational decision? How does this strategic decision drive the value for the key stakeholders? Those organizations are doing the best, are actually performing the best. They're having the highest margins. They're the ones who are actually, because they can tie it to why are we doing this? And it is for the community and for the patients, and be able to drive that forward. So understanding, keep in mind, quality of care costs money, right? There's no safety, there's no quality that doesn't cost something. And so understanding that actually why we're making these how these quality factors, because a lot of people, especially in organizations I work with, the CFO thinks of quality as, that's the fluffy stuff that the CNO is paying attention to. They're paying attention to our scores. Unless you're actually already on a risk-based reimbursement model, it feels like the fluffy stuff. But understanding quality metrics and understanding what's happening to them is a key part of that data-driven decision-making. And it should be looked at with that mentality, instead of just seeing it, okay, the quality scores are separate from financial. We're going to run things based off of the financial metrics. You need to be paying attention to the quality metrics and data at the heart of that decision making. And obviously, last attribute we see is those that are a better performing practice by definition are profitable, right? They have a lower operating cost per unit of output and greater revenue than their operating costs. We actually see profitable rural health clinics. My colleague Eric Shaw always points out, if you're an RHC who historically that you're grandfathered in, where you got that cost-based reimbursement, you shouldn't be losing money in the RHC. Just because around the country we're seeing organizations on average losing 100 or subsidizing primary care and primary care clinics at $186,000 per provider, rural health clinics should be at break even at least. So he's seen, we've seen that most organizations we know are not doing that, and it's having to do this data-driven operational improvement to get to move towards break even, and from where they're at right now. So let's take a look a little bit at what we see also in better performing practices compared to what we see in all practices versus rural practices, because there is a difference. But I want to be very clear, when we say better performers, and we looked at this data from MGMA, when we talk about better performing practices, they're not all in urban markets. It's not a simple matter of, okay, well, the urban ones are doing better, and so therefore, we don't even need to pay attention to what is going on with a better performing practice. We just, we want to focus on what's going on with the rural practices. I have to say, the better performing practices is helpful information for an RHC to be paying attention to understand what is possible. One thing I will say, though, is let's just say you as an RHC that are listening to this, thinking, okay, in rural healthcare, maybe we're losing $112,000 on a per provider metric, right, in rural. And, we as an organization, we're at $96,000. So we're doing better than the rural average. Is that, frankly, that's still not a sustainable number. We know that we need to actually make adjustments if we're going to get to financially sustainable numbers. And so if I'm a rural organization and I say, okay, well, I'm beating the median level for rural, well, let's go to the next benchmark of a better performing practices is only losing 73,000. How can I get to that? How can I constantly be moving the needle towards financial sustainability within these practices, and understanding and monitoring that data? What does 10% improvement look like? What does each year after year after year? And what can I do to just drive 5-10% improvement in each of the different metrics I'm looking at? So whether it's medical revenue, how can I drive up medical revenue just 10% next year? How can I look at my operating costs and make sure I'm at least, if I can't improve my operating costs, especially with what's going on with inflation, how can I do it on a per unit basis where I'm getting more efficiency out of what I'm actually investing those costs in to drive a higher ROI? One of the key things that I want to point out is with regards to staffing, the fact that we're in a staffing crunch. A lot of organizations have lost their clinical support staff, have lost MAs, et cetera, and thinking, because I can't get the staff, I always hear, well, we would be able to do better if we had more staff. When we look at this and we see better performing practices are actually being able to do that better performance with only 1.3 clinical support staff per provider, as opposed to what we see in rural of 1.47. What that tells me is that there needs to be an increased focus on our processes and our workflow of what's going on in the clinic. It's not about how can I go and hire another MA. Sometimes we do need to go out and hire another MA, right? We have a physician rooming patients, but a lot of that is looking at the information of what are we doing in each one of our processes and how can we change that to get to to work with what we have. Because there's not right now another MA to hire. And the fact that I can see my better performing practices working more efficiently and doing more with less tells me it's achievable. Sometimes we have competency variances that are happening that we need to address, and it might be training, it might be a workflow piece, but having the information and that data is how we decide what are the things that we want to change in order to address the issue. The other thing I want to point out that is very specific for rural health clinics is what is notice on the work RVU productivity chart to the right, that our better performing practices have significantly higher throughput than what we're seeing right now in our rural practices. And the reason why that is multivariate, but one of the key things that happens that I see especially when people convert to a rural health clinic is, okay, we have an all-inclusive rate. They stop paying attention to the CPT code distribution. They're not paying attention to their billing and their coding. And so they start getting, especially on the commercial side, not necessarily getting paid for everything that they do because they've lost some of the discipline associated with their charting. They've lost some of the feedback mechanisms that happen from doing a CPT coding distribution and giving the feedback to the provider of saying, hey, doing a chart audit, your documentation was missing X, Y, and Z. And if you put that in there, I could bill it as a 99215. Because we're doing that all-inclusive rate, some of that gets lost, and that is driving some of the significant work RVU productivity differences between rural clinics and our better performing practices. And while it doesn't matter on the Medicare reimbursement side, it does matter on our commercial side. And so we're losing out on revenue associated with that by losing that discipline of looking at some of the data that is important for our rural health clinic to continue to monitor, even with a change in what we're designated as. So when it comes to grounding in data, we have to make sure we're working with clean, meaningful data. What happens when you don't work with that data, right? If you have inconsistent data that doesn't reconcile, we see that all the time, where we're going to pull from, somebody pulls from this system, another person pulls from another system, finance pulls a number versus the practice manager understands. And why do those numbers not make sense? Okay, and we see it even at the most base level. We don't know exactly how many visits we're seeing in the clinic. Somebody pulling the data from a report of that from scheduling versus finance pulling it from billing, and those numbers don't match, and we just accept it. We don't figure out why the numbers don't match, and we don't act within our team to understand that missing information. So you then lose out on the opportunity to engage an entire team around a problem to work through it because they don't understand why each other's making certain decisions because they're not even looking at the same information, which leads to blind decision making. That blind decision making is highly problematic because we don't know if we're making the right decision and there's nothing to substantiate when something does work. Should we double down on it versus not? Do we continue? And then we don't even see the different opportunities that we could take advantage of to actually make some of the changes we need to. So it all starts down with, can we start out with clean, meaningful data? Can we pull information? And yes, we can recognize that pulling reports from multiple different places, it may not match. We have to go through the reconciliation process of understanding why they don't match and how can we get them to make sure we're making it like apples to apples comparison instead of just accepting, okay, we accept that they don't match. They're never going to match. Let's move forward anyway, because you're not going to be able to have that solution focused team engagement around a problem to actually address the issues. Okay. What starts out as a really small problem of maybe, hey, not everybody's engaging in it. We're making decisions and I don't understand why things don't reconcile. These always lead to much bigger issues, right? There's a snowball effect of it, right? And in doing that, we end up impacting the overall operational performance of not just the rural health clinic, but now the entire organization. So we might have increased turnover expense. We have providers leave. We have, people, the clinic we don't consolidate our clinics under our cost report. And so we miss out on significant reimbursement opportunities. So those pieces snowball into one another. And this is why starting out with the very baseline of having really consistent data that reconciles and understanding the why behind it is so critical. One of the most costly things that I've actually seen happen involving a rural health clinic, though, is a case, and I'm actually working on a case right now as an expert witness, where it's a Medicare false claims case, where oftentimes the False Claims Act and such, there's technical violations, and not being able to support your decisions with that data and having that background information means you can't explain why all of your claims were accurate, and then you end up having penalties under a Medicare false claims. And the organizations we work with, these rural hospitals, we can't afford the multi-million-dollar settlement that needs to happen to deal with a Medicare false claims issue. And so that can shut down an organization very, very quickly if we let things snowball and get out ahead of us with regards to our data and our decision-making grounded in that data. So how do you utilize this data, right? One of the important things is you have your reporting, and you can repeat it on a regular basis, and understanding what is that regular basis that I need to engage with that data. Some information needs to be dealt with daily. Some of it is weekly, some's quarterly, some of it is just, hey, once a year, compare it to last year. But understanding for each piece of data, what is the standard that I need to be able to do it at, and knowing that I can replicate it at any given time is critical for understanding, making sure I'm starting out with the clean, meaningful data. Okay, we have that one version of the truth. I was talking about that lack of reconciliation. Yes, sometimes you have to say, these two reports will never look the same, but here's my reconciliation report that I know that every single time will tie them back together. And I've tested it multiple times so that I know that I'm always comparing apples to apples, right? I have one version. It's not, hey, the CFO said X and the COO said Y, and I don't know which one to listen to. So I'm going to make my own decision and move forward and hope it's the right one. Okay. Being able to have that information is what allows you to have that consistent roadmap and to go back and actually test. If I change something, I can go back and look at this roadmap to say, all right, this is what it was previously. Based off of this data, has it changed in a positive way, right? What am I actually following to get there? And here's what I'm expecting it to see. If I want to have a 10% improvement, here's what I'm measuring. Here are the 5 different metrics that we're looking at. Did they change? And if we continue down this, will it continue to progress, or have I hit as good as I can get with that? Right. Also, right, I work primarily with providers. And one of the things that I always hear is, in God we trust, all others bring data. If you don't know that you're starting out with cleaning meaningful data, and you can prove that you're starting out with cleaning meaningful data, you're going to have a very hard time driving any sort of process improvement with providers or working with operations with providers. Because one of the things I've seen is you can get bad data in front of providers a grand total of 0 times. Because if you don't, every single conversation is questioning the data. It's, I don't think that's right. This doesn't match what I would think it would be. And if you can't say, okay, here's how I know that the data is right, you're going to have to constantly be fighting against that provider's gut instinct as opposed to real information. So you can see how that puts you down a rabbit hole of not being able to be solutions focused. Okay. Also, when you have that cleaning meaningful data, doing it at a regular cadence, you find problems right away. You can address an issue. Dealing with provider compensation, one of the key things that bothers me is when I see an organization say, we're going to give you your quality, you're going to be paid on quality, and we're going to give you a report as to how you're doing on quality once a year. And, oh, by the way, so it's December, and we're going to pay out compensation. And the provider's like, well, this is less than I thought it was going to be. Show me the information behind how you calculate this. And it shows, by the way, back in January, as part of your quality metrics, you put hey, you have to close out charts on time because we wanted to make sure the complete patient information there. In January, you really didn't close out charts. Well, if you tell a provider in December that back in January they did something, that's not going to change their behavior one bit. They don't even remember the patients they saw in January to change how they were behaving back then. And so when you're not doing things at the right cadence, problems may exist. And oh, look, January turned into we're not doing the right thing in January, February, and March. And so you end up having that snowball impact. You want to be able to look at really utilization and throughput, and you can actually assess them, because utilization and throughput of all of your resources, but especially in the rural health clinic of your staff, is how you're going to drive that operational improvement, right? Productivity is not just about working harder. It's not, I've never seen an organization really drive performance improvement by telling the provider, just see more patients. It never works that way, right? You need to be actually have the data and understanding utilization and throughput of what's creating the bottlenecks. What can we do more efficiently? What process can we change, and assess that in a way we're using that clean and meaningful data to be very solutions focused and address the real issues, as opposed to just telling somebody to work harder. And as a result, you can have both short and long-term efficiency improvements. Some of them are going to be very short. It might be a temporary, like we don't have the IT infrastructure to do our proper no-show rates. Let's just track it on a Post-it for, like everybody, like every single time you have a no-show that day, write it down on this paper, and we'll start doing it at the end of the week, examine it. And okay, now we're getting information. How can we do this more efficiently, until we have the ability to involve it into our charting templates, not waiting until here's the long-term solution. Let's go ahead and have that short-term improvement and have more efficiency now that we can address, and we can integrate it into longer-term issues. All right. And that being the case, one of the big things, as I mentioned with the consolidation, is involving people across the multiple departments. Is the RHCs oftentimes we're seeing they're the ones who get left out of some of the decision making, but they have some of the biggest impact on the overall performance, especially on the revenue cycle piece of things. Is if you consolidate all of your billing operations and the front desk people are no longer involved, all of your insurance verification happens, your patient check-in, your demographic verification, your co-pay collections, your patient balance collections. None of that stuff happens appropriately when you don't have all engagement across all of the different departments. So what are some of the different data pieces that for operational improvement and for running your RHC that you should be paying attention to? So this is just, by the way, there's an organization that many of you are familiar with called LilyPad that is a great data management company as far as finding out information, helping RHCs specifically look at where they're benchmarking against different staffing metrics. But one of the things that I like is really looking at information of saying, okay, what are the appropriate different metrics I need to be measuring by category to understand give me a starting point of what's the data I should be looking at. So there's key areas around staffing metrics that I want you guys to be paying attention to. So understanding what your charges are per total staff, your net revenue per total staff. What are your patient visits per total staff, right? Like when you're thinking about this. This way you can have a normalized way of saying, okay, how does it compare period to period? What are my visits per total staff? So that way I can actually see if I change things, right, such as that staff number, I understand what's going on in my ratios, and not having an issue where, hey, I actually was able to, I was actually able to hire an additional MA. Look, my patient visits per total, my patient's visits have gone up, but it's because I added in an MA. That doesn't really tell me whether or not I'm being more efficient. It just tells me that I have added in additional staff. Versus when you look at the data in a very normalized way, it'll actually be able to give you an apples to apples comparison when it comes to, did this process improvement thing actually work? So here are some staffing metrics that will definitely help you looking at how you're actually utilizing your people, right? That being said, there's also productivity metrics. And I break out oftentimes productivity being different between the physician versus the APP. just because within the rural health clinic, we're monitoring different things with regards to the threshold, right? We have different targets that we're supposed to hit. Even if we consolidate them, we still have to understand what is the difference of what is our throughput for a physician versus an APP. Okay. Looking at your work RVUs, your new patients, and your panel size on a per FTE basis is really important for understanding, okay, how are you guys performing? Are you guys going to be able to hit that RHC threshold to be able to hit those minimum numbers to be able to maximize your reimbursement? By paying attention to what your new patient ratios are, hey, are you actually growing as an organization? Are you actually expanding that population that you're actually able to provide care to? What is your overall market share within your group, so you can see what is your primary care footprint and how is that going to drive the overall care for that organization. With compensation metrics, understanding relative to, so that this helps you understand whether or not where you are relative to market and how competitive you're going to be, which is really important for Stark and anti-kickback compliance, is what is your salaries and what is your overall compensation per provider. If you have no variable compensation, I mean, you're not having that kind of bonus structure where it's incentive or quality care, et cetera. That, I will say, you've moved away from best practice. You want to actually make sure what percentage of your total compensation is variable versus fixed, and making sure that that variable compensation as a percentage of actual total compensation for a provider is actually increasing. What we're seeing most organizations at right now is having about 20% of total compensation for a provider be at risk, be in that variable bucket, right? And it should be based off of historical performance. So it's an incentive that somebody can actually hit and do better under an incentive structure rather than everything being tied up in base. Having understanding your quality metrics. And one thing that I hear all the time is CFOs saying, okay, quality metrics are separate. You guys need to know that for making sure that we're doing our MIPS reporting, our PQRS, our talking to our ACO. We need to measure quality for that. But realistically, as I was mentioning earlier, is our better performing organizations understand, they look at quality metrics next to the financial metrics, so that when they make a change, they understand that they can't do it at the expense of the quality metrics. And also understanding how are the quality metrics, if we want to focus on childhood immunizations, right, where are we on that percentage? What is it going to cost us to actually increase that? What are the different metrics that we're going to have, or what are the different financial investments we're going to have to make, or process these investments to be able to drive some of these quality metrics up better? And sometimes that's an investment of getting access to better data. All right, so let's go through some of the best practices. I did some overview with regards to what is, starting out from a strategy perspective, how is that looked at very holistically across an organization, and where does the RHC actually fit into this? So there's different pieces that you actually are going to measure to understand where are you on your strategic risk profile, right? Understanding where your budgets are from a financial piece of it. Understand what's going out in the market. So do you have the right provider complement? Can you identify different growth opportunities? Part of that is actually doing the data of having your referral information, right? You can't identify, again, as far as identifying growth opportunities, understanding where the patients currently are seeking care and what kind of care, and especially in your rural health clinic, understanding what are you sending out? What are you having to send to specialists at other organizations, out of the community, et cetera? It's amazing given how much that's needed for understanding what is the appropriate provider complement. Most organizations are not tracking their referral data. And they say it's because it's not easily available in their EHR system. You don't always have to go to technology. While that's great and it's ideal to move to a very interoperable integrated system, I would highly recommend everybody actually go ahead and work on tracking that referral information. What's, between primary care, specialty care, and the different ancillaries, where are they actually sending patients in any way that you can, even if it's a simple Excel spreadsheet. having people monitor it, having that piece of paper next to the check-in desk or the scheduler, et cetera, to be able to monitor that is really important for driving your actual making really good decisions for your organization and driving that strategy forward. Sometimes data is as simple as having a checklist of making sure you do things every single year, such as reviewing your payer contracts and your provider contracts. They should be reviewed on an annual basis. Having that kind of tracker and knowing that you did it, that's meaningful data to know that you actually did this and what was the result and what changes needed to be made. That's information to know that you are doing that will drive your performance forward. So it doesn't always have to be really, really complicated running of reports that you have to do to be able to move that forward. So let's talk a little bit about how you should look at your provider complement strategy, okay, and how you're going to utilize data in that. One of the big things that I see that really drives that provider complement strategy is having a real medical staff development plan. I mentioned previously about clinics or hospitals being very opportunistic when it comes to clinics. A key thing is a community health needs assessment. Most organizations that are listening to this reckon and are listening, thinking, I have a CHNA. I use it as a check the box for the IRS. The IRS makes me do it every 3 years. It's published on my website. And that is what they do. They farm it out to an accounting firm, or maybe their foundation does it. And they do this survey and they publish it. This is what my community needs. They don't use it to actually drive their provider complement strategy of saying, here's what the community needs. Here's how can I utilize this and put it into a medical staff development plan of recognizing how many providers do I need, of what specialties, to be, what are the service areas that my community health needs assessment tells me that that my community needs more behavioral health, needs more pulmonology, we have a high diabetes population. Maybe we could have an endocrinologist. Maybe I need family medicine that has that kind of background and combined with some diabetes educators, right? Actually utilizing that CHNA to help integrate into your provider strategy is a key initiative for making sure you're focusing and making the right investments on your recruitment strategy. Which providers do you need to bring into your market? What are the retention risks that you have associated with it? So, and where is the best place to put them? Is it in the RHC? Is it in a standalone clinic? Having all of those pieces put together, you can see how important it is to have the different pieces of data to look at that very holistically, as opposed to in the isolation of, oh, I know that Dr. Jones is going to retire. She's been in the area for 40 something years. She sees this many patients. I better recruit her replacement, right? So the key piece of actually understanding the data behind the provider complement is understanding, okay, here's my medical staff. Here are the different specialties. Here's how old they are. So what is my potential, retirement risk? And I have to say, within this post-pandemic stage, that there's a significant number of providers that actually, it was something like 86% of providers that are over the age of 40 said if it was financially feasible in the next 3 years, they would consider retirement. Age 40, not 60, not 50, if it was financially feasible that they would consider retiring. And so while it's important to know the age of your providers, and most provider needs assessments are going to start out with thinking that those who are over the age of 65 are either going to retire or going to be scaling back, you need to make sure you're having that conversation across the board with your different providers. But so people sort of look at their provider complement of how many do we have in the market. The next step of the data that I want you guys to look at is actually understanding the revenue associated with each provider. And that includes looking at, okay, new providers. So you can see on this example here, the provider at the bottom wasn't there in 2019, 2020. It's understanding the ramp up of a relatively new provider, like the second from the bottom, right? This is a provider who's increasing the amount each year because this was a relatively new provider, of how long is it taking them to ramp up over time. And you notice that this is actually during a pandemic that they were able to ramp up. Also associated with the fact that one of our highest producing providers in this scenario is nearing retirement age and is responsible for 20% of the total revenue associated with this clinic. So understanding that risk profile of what does it mean for your provider complement in your medical staff development planning is a key part of that information, right? It's not just knowing how many FTEs you need, it's understanding what is the financial investment behind this, what needs to be able to shift. The piece that's not on here that I would also look at is okay, if you look at it holistically of matching data together, here's the retirement risk, here's the revenue associated with it, here's everybody's productivity. Maybe I have somebody who's only at 20%, productive and had 20th percentile of MGMA. If they got up to the 50th percentile, maybe they can absorb some of that risk associated with a near retiring provider while I'm trying to recruit an additional provider into the organization. Instead of just making the assumption and creating a lot of dissatisfaction with some of your providers of we're just going to increase everybody's patient panel size, engaging with providers with this level of information actually helps drive that overall engagement. Another piece that we see is that most organizations are really in the RHC using really practice supervisors rather than managers. Forget the title that you're doing them. Think about it from a roles and responsibilities. Oftentimes we have your lead MA or nurse is working, they're able to monitor the schedule. They make sure, hey, somebody's sick, we're going to fill in, we'll fill it in here. So you guys need this, management needs this report. Here, I'll pull this report for them. And part of that is because we have a tendency to say, who is our most senior MA that's in the practice? Let's make them lead MA, right? They're the supervisor. But they don't provide any training to shift from being a supervisor to a manager. And the things that if you look at the roles and responsibilities for a real manager of responsible for the success of the practice, engaging in the financial management, engaging with leadership and physicians, being part of strategic planning, communicating with stakeholders, actually doing gap analysis and coming up with ways to improve things. That's not something that people just are born with knowing how to do that. I have an 11-month-old. I can promise you he doesn't know how to do any of this stuff. They have to be trained and taught. And so in a place where a lot of our RHC managers are actually still wearing the hat full time of an MA or a nurse, right? They're working full time as that. When are they going to learn these skills if we do not take the time and the investment to teach it to them, right? And then give them information to monitor their performance of what those expectations are. Organizations for becoming a best practice organization, take that time to do that kind of training, even if it means reduced productivity and some staffing constraints on the front end. So one of the methods that I utilize is actually I will do training with managers, take a half day every other week and identify a piece of something I want that staff manager to actually be working on and give them just that. And then we come back and revisit in 2 weeks, and then we add something else to that list. And you do this over the course, and you do this about 6 times, right? Or 12 times, do it over the course of 3 months. And then start showing them how that's actually improving and give them things to actually change of take this on as a project, almost like a capstone if they were in school of make this more efficient. They learn the skill sets while still helping the practice actively. And you actually see that improved performance. That being said, when you are training them, you need to train them around the data that they need to be doing. Real management for an RHC should be looking at. So I have on here under the third bullet, here's a list of all these things that management should be really focusing on for driving performance. That's a long list. Most of the people that you are going to have that start out as and become the supervisor of the clinic, they might be familiar with visits and work reviews per provider. They might actually even they understand the scheduling metrics. They might even understand revenue per provider. Most of them have never engaged with the AR per FTE physician. Most of them have never worked with CPT code distribution. They might have never done understanding deficiency and denial rates. You have to train them around the data and why is this data important? How are they utilizing this in their decision making? How do these pieces play out? If you never teach them about how to utilize that data, they're never going to be able to actually utilize it for improved decision making. And then what's the point of having a manager of the clinic, unless, of course, you really do just want them to adjust the schedules for when somebody is sick. You're never going to get to best practice or an improved performance RHC if you're the people running the organization or running the clinic don't understand the data that will help them come up with the right decisions. Okay. That being said, you also have to be engaging with your providers around data. A lot of people assume that providers really just want, like, they only want to see patients and they only care about the productivity information that they're compensated on. Maybe they want to know some patient data. I understand where that mentality comes from, especially post meaningful use, where so many people got burned by these huge investments in IT that never gave them information to actually have better evidence-based decision making for their patients. It felt like a waste. But realistically, what we have seen with providers is if you will actually work on provider engagement around some data and explain why you're doing that, and talk to them about why we're looking at this information, and show them also how they can utilize it to better participate in decision making for the clinic, providers will very, very happily engage with you with regards to information, especially around financials. If they understand the revenue and they understand the expenses of saying, hey, listen, your productivity is at this level. We need to be able to you want us to make this kind of investment in the clinic. We want to bring in some additional training on the EHR, but it's going to cost this much money. Can we see an additional half patient, average of an additional half patient per day to be able to do that? So let's just say we need to see 2.5 more patients per week. Well, if you actually engage with the providers about here's what that will do from a revenue standpoint, or for example, on the RHC, engage with them of this is what the threshold is. And here's when we don't meet the threshold. Here's the impact to revenue versus when we do. Providers will engage with the management and administration to say, all right, I am willing to participate and look at workflow of what can I do? What can we do as a team? How can I work with my nurse better in order to be able to improve that throughput so we hit threshold and we can get the best reimbursement for the clinic? And they'll be part of that solution thinking. When we look at overall clinic operations, right? I talked previously about that standardization. Utilize data to figure out what is appropriate to standardize. Standardize does not mean one size fits all. One of the things that I will never do, I am not a clinician, I will never go and tell a provider, this is how you see a patient, right? Here's how you should triage a patient. Here's what this is. What I can do though, because as a non-clinician, is I can give data to my providers of saying, all right, on average, primary care providers can see patients, here's the average throughput, and they can do very well on a scheduling template of a 2040. Specialists might be on a 1530 because they're doing more of the procedural follow-ups, right? And having that kind of discussion with providers, being like, even within my own organization, one thing I will track is what is my average throughput per provider? Get all the providers around and say the APPs have a throughput of they're seeing 2.3 patients per hour, physicians you're seeing 0.9. And then an individual physician can say, wait, why am I only seeing 0.5 patients per hour and this provider is seeing 1.2? What's it going to take to, if everybody can at least see the average number of patients per hour, what are you doing? They can have peer-to-peer conversations of what are you doing differently that you're able to see an additional patient per hour than I am? And they can engage with that. That meaningful data of giving that to them starts that conversation, really just drives that performance improvement. And then making sure, again, I said you can put bad data in front of a provider 0 times. It's helping explain to them how to make the data actually comparative and an apples to apples comparison. And so it's important to show them the information such as, here's the panel mix. I'm saying this provider saw this many high acuity patients versus me, because that's often the go-to when I show them throughput information. They're like, well, of course, Dr. X can see more patients per hour than I am. I'm having to do all of the, the Medicare annual wellness visits, and those take 45 minutes to an hour each. And when they see the data of sometimes maybe they're actually seeing the same total number, it's easier to engage with them with that kind of information. When it comes to standardization, really looking at the scheduling and the staffing and seeing how standardization fits into those different pieces will help you drive operational improvement. So when it comes to scheduling, we have to understand that scheduling is a big patient dissatisfier, right? 1 in 5 patients will say that a long wait time will they will actually switch doctors if they're having to wait too long, right? They 30% of patients will have left a doctor's appointment because they were waiting too long. We live in a day and age where people have increased access. There's the Walgreens in their Minute Clinic. There's Walmart now has primary care in it. People are utilizing Amazon as their pharmacy. When they see this kind of stuff, accessibility and convenience is actually really important. So are we actually making sure we have good data about our scheduling? What is our door to doc time? Again, if the standard right now is less than 20 minutes from door to doc time and we're at 37, let's not focus on how we can get from 37 to 20. Let's worry about how can we get from 37 to 34 and then from 34 to 31. What are the different pieces? What are causing those bottlenecks for us to change our process? Okay. What is it? Because we're starting every day instead of at the first appointments at 8, but we're not actually getting started until 8:15 because of what time we're doing huddle. What are we doing that needs to actually adjust so that we don't have kind of these scheduling issues? Making sure that you have a realistic appointment schedule, and that you're not doing too much at once. And so when you're changing something like a scheduling template, that you're not trying to actually do, okay, here's what's best practice. How do we need to phase this in to be realistic and actually drive that kind of improvement? One of the key tools that I use is a time motion analysis of understanding what is everybody doing in just a 30-minute period and what identify the waste. I can't have a physician wasting 2.6 hours per day if I monitored them for 30 minutes and say, this is basically an average half-hour block. This is what it looks like for the physician. I can't afford in this day and age to have my physician lose 2.6 hours per day. They can be charting, they can be seeing patients. 2.6 hours per day, you're talking about easily 3 to 4 patients right there, right? Of being able to see them from that throughput. It's really important also from a data perspective to understand what can my APPs do within my clinic. As RHCs, we all have APPs in our clinic, but it's important depending on, with Oklahoma being a restricted practice state, what can they realistically do and what do I need to have a physician actually do from a supervision perspective? What is in my collaboration agreement? And not just checking the collaboration agreement, but looking at the payer contract, because the payer contracts tend to be more restrictive than the state licensing board. Even in Oklahoma, we have seen payer contracts that what they'll get you on is they'll say that the APP can do X, Y, and Z. They can do all this stuff within their license, but we're going to reduce your reimbursement if you don't document it this way, or if you have the APP and not knowing how that is. People miss out on the information of what is the best way to use my APP because they're not comparing what they're allowed to do under their payer contract and how the payer actually wants them to appropriately document that to maximize the reimbursement. I mentioned about revenue cycle, so finance and operations and the data associated with that. Understanding what your cost to collect is a really critical measurement for understanding how well your and how efficient your revenue cycle is working and how that number shifts over time. Making sure understanding the components of cost to collect and where the RHC fits into that, especially, we look at it as thinking of, okay, we make sure that a third-party vendor fee is in there, but I have to say, paying attention to third-party vendor efficiencies. How well do they actually understand RHC billing? And measuring that is really key for evaluating whether or not that's the right vendor for you and whether or not the cost is worth it. You might go with a vendor that says, hey, we're going to take 5% of collections. Hey, that sounds a lot better than the vendor who charges 7.5% of collections. But if the person who charges 7.5% collections really understands the RHC billing and can do it correctly, then I would much rather pay the 7.5% on a significantly greater revenue that they're going to be able to process and do correctly and give feedback back to my providers and my front desk staff on how that is working. So when you look at revenue cycle, and especially within the clinic, think about revenue cycle. Oftentimes when you consolidate it, they're focusing on the transaction processing in the back end. All those front end pieces, that's happening in the RHC. So if your RHC leadership and your front desk people are not part of your revenue cycle meetings or are not thought about in there, this drives everything down that claim life cycle. You have to get it right on the front end of it. And so what are you measuring from a data perspective in the RHC that impacts revenue cycle? And is that information getting back to the revenue cycle team, right? This is where we see a big disconnect of what's going on in the hospital versus the clinic, and that us versus them mentality is we're collecting data within the clinic, but revenue cycle is not using it to say, how can we come together to make sure we can do a better, be more efficient with our prior authorizations and drive overall, the performance improvement. So I mentioned I like to give people tools and checklists. Here are some revenue cycle to-do lists. I'm not going to go through each piece of these. I just wanted to make sure that you guys had checklists of, and like I said, the tools like the time motion study analysis, doing a provider complement risk. So here I just have a couple of slides on here that I want you guys to print off and go through. And here's your to-do list of, hey, check, am I doing this? Am I doing that? And like I said, data can be as simple as a checklist of regularly go like print this off and check, have I done it? If not, when's the next time I need to do it? Or if so, when is the next time I need to do it? If I haven't done it, when can I have a date certain that I'm going to have this done by? So I wanted to leave just a minute for questions. So to wrap up, really understanding what is driving those losses in our provider clinics, and understanding what drives those losses helps you actually identify what are the things that we can appropriately address. And then thinking about it from a data perspective, how can we quantify this and use that to make better decisions for identifying what do we want to change? How do we want to change it? What are we going to start measuring to make sure it's actually being effective? At what cadence do we want to measure it? What is the data that we're going to need to support these kinds of decisions? And how frequently are we going to go back to it? Who are the right stakeholders to engage with all of this data and information to make sure we have the best ideas coming out and we're actually know that everybody it's impacting has been notified or is engaged in the solution focus for this? Because recognize that all of our best performing RHCs, they're looking at it holistically of strategy, staff, providers, what are the resources, what's the technology, and looking at it in that holistic perspective. These things drive financial performance. If you go through each of these, you will see improvements in margin and that financial performance by utilizing this data well. So that being said, we've got a minute left. Laura, I don't know if we have any questions that we want to go over, but if not, I want to make sure people know how to follow up with additional questions if they think of things as they're either looking at the recording or here. I always think of things on my way. I used to say on my way home, but in my case, now that I work from home, on my way to the kitchen.
Thank you, Opal. Yes, I completely agree. A week later, I'll come up with a question or something. So thank you so much. Lexus, I know you've stayed on the entire time. Did you have any questions or anything that you'd like to ask?
No, I think I'm good until, like you guys said, a week later, you'll come up with a question.
Well, no worries. Please feel free to reach out to me. Also, Opal's contact information is here in the middle of the screen. And thank you all for your time.